Dr. Vineetha. Dr. Vineetha is working in the medical oncology department in corporate hospital in Kochi as a pain and palliative care specialist. She got her training from Institute of Palliative Medicine, Calicut, and she got her post-graduation in palliative medicine from Cardiff University. And she also has completed her MD in community medicine from Amrita Institute of Medical Sciences, Kochi. And she has experience in working with the oncology team, integrating palliative care in oncology in various settings in Kerala. And Dr. Vineetha is our faculty for last few years. Thank you, Dr. Vineetha, for taking this session again for this group. Thank you so much, and over to you.
Hi, everybody. Very good afternoon. And I think there is my camera's a bit hazy, but I hope it is fine once I go to my slides. So let me just try sharing my screen. Is my slides visible?
Yes,
Is
ma'am.
my
Yes.
slides visible? And are they changing?
Yes, perfect. We are good to go.
Okay, all right. Yes. So hi everybody. Today we will be starting off with GI symptom management in palliative care. So generally we used to take it through different classes covering nausea, vomiting, constipation in one class, and then bowel obstruction in another. But today we have combined all of them and trying to make it crisp. Yet we would love to have space for interactions, and please use the chat box very frequently, as in when we are going through the topic, because this is basically a platform, not just for a one-way lecture. All of us are working in different settings, and GI symptom is so very common, and all of us are managing different GI symptoms in our clinical settings. So, the specific learning objectives for today's session would be uh, to be able to enumerate the types and causes of nausea and vomiting, constipation, and malignant bowel obstruction, and to identify and diagnose the type and cause of each of these, like what type of vomiting it is and what is the cause, for example, and to describe the management of these symptoms and pharmacological and non-pharmacological management. Okay. So before we move on, uh, would you like to just put in which is the most commonest antiemetic that you use in your practice? Please use the chat box. Which is the most commonest antiemetic? Yes, Dr. Kamakshi says ondansetron. Yes. The commonest antiemetic generally that you would prescribe, Dr. Abraham says metoclopramide, Dr. Mudunoru says the ondansetron, Dr. Virendra says again ondansetron. Yes. Do we have any more? Yes. So most of the times, I mean, yes, we do have a lot of them coming up. Say, Dr. Nivedita also says ondansetron. Dr. Kamashi says dexamethasone. Yes. So we have. So we all know that there are so many antiemetics that is there in front of us. Yes, Dr. Lakshman also says on that. So there are so many antiemetics in front of us, and how do we choose? This is the most appropriate antiemetic for this cause. So when you have a patient coming to you and telling that, doctor, I am having nausea and vomiting, so we tend to immediately take up a pen and prescribe either a metoclopramide or a ondansetron, right? Most commonly. So where is that point where we have to decide, okay, probably in this case, metoclopramide is not going to be helpful for him. Or maybe in this case, metoclopramide might be having more adverse effects for him. So this is what this class is all about. It is about familiarizing with the symptoms that you come across in your case scenarios, but looking at it in a little more different angle, where we can help to relieve the symptom of the patient by dissecting into the cause and finding which receptor level the exact action that we can propose for this patient, and thereby giving a complete relief for that. Okay, so let us start off right now with a case scenario. So this is a case scenario that I would like each of you to just go through. And I have put the clues over here, like the highlight points over here in red and blue, so that you are able to focus on it much better. And just have a look into this and think what would be your answers over here at this point of time, because we are going to come back to this case after today's session on nausea and vomiting and constipation. And let us see how different we can think about the answers there. Okay. So this is a 54-year-old frail lady with gastric carcinoma and on chemotherapy. Was admitted in the general ward for treatment of urinary tract infection. So she's on chemo and she's admitted for urinary tract infection. And she was admitted with nausea, she is admitted with vomiting, abdominal colic, and fever. She is tired and has been admitted for completion of IV antibiotic. She has small, infrequent, incomplete. She has small, frequent, incomplete bowel movements for 4 days and has been started on laxatives. She is accompanied by her younger daughter. Now, the question is, what are the issues here and how would you like to investigate this patient so that you can plan your marriage? So like I said, please think about what could be the issues over here and how would you investigate this patient and how you would thereby manage this. And we are going to come back to the same case in a short while. So coming to our core topic for today is emesis. So it's basically a defense mechanism. It's not that bad. It is a defense mechanism to remove the toxic and harmful substances from the body after ingestion. And generally, it is of 3 phases, that we say nausea, when actually the contents are not coming out, and when there is retching against a closed glottis, and when there is contraction of the diaphragmatic muscles, and when vomiting happens, there is actually the contents that is being expelled. So what are the different types of vomiting? What do you think? What are the different types of vomiting? Yes, Dr.
Projectile, non-projectile.
Yes, projectile, non-projectile. Then Dr. Geetanjali also was talking about chemo-induced nausea and vomiting and constipation, right? So, okay, now that is the cause over there, right? So now what are the different types of vomiting? Suppose I say in terms of time. So someone who, like say chemo-induced vomiting that you were talking about. So someone who starts vomiting right away after being administered chemotherapy, and someone who starts vomiting after hours of chemotherapy. That would be something you call as acute vomiting and delayed vomiting. So acute vomiting is that which occurs within minutes to hours, and it generally resolves in about 24 hours. So whereas you have delayed vomiting, so most of the chemotherapy drugs, the radiation, they all have delayed vomiting, which we call as, CINV, RINV, chemotherapy induced nausea and vomiting, radiotherapy induced nausea and vomiting. So these usually occur after 24 hours of the chemotherapy, and they get worse from about 48 to 72 hours. And for some, it lasts for about 7 days. And nausea is most often it is precipitated because they are not able to take the smells. It's like a kind of pregnancy kind of state where you get very sensitive to different type of smells, and that itself causes a trigger and becomes a reason for nausea. So here we also have something which is called as breakthrough vomiting. So when you have a patient with vomiting and you have put the patient on 3 times daily of metoclopramide, and your patient comes to you back again with vomiting, and the patient tells you that, yes, doctor, I'm fine for a couple of hours after the morning dose, but before I take my afternoon dose, I start vomiting again. So you have something called as breakthrough vomiting, something which occurs before the next dose. And then you have refractory vomiting. Okay, metoclopramide is something that we probably can give at a frequency of about 6 hourly also. Okay, some very severe situations. Sometimes there are situations that we even give 4 hourly. So if you are giving like 6 hourly for a patient who was having a breakthrough vomiting, and still the patient is having vomiting, and then you call it refractory vomiting, is not able to manage with the current antiemetic regimen. And then say, suppose your patient who has gone for a chemotherapy, for example, something like a cisplatin-based chemotherapy, for example, which is one of those drugs which has severe nausea and vomiting. And that patient tells you, oh, last time was horrible. My first cycle was horrible. The moment the medicine started, I just started vomiting and vomiting. I was unable to eat or drink, or it was such a horrible experience. I do not want any more injections. They go into that kind of frame of mind. So much so that, the next time they come, even before the chemotherapy is administered, they start developing nausea. For some, it is so bad that they start developing nausea and vomiting even the day before the chemotherapy. So that's called something like anticipatory vomiting. Now, mind you, it is different how we tackle the vomiting for each of us. So anticipatory vomiting, there are certain drugs that prefer to do or to advise. And are you aware of what could be given for an anticipatory vomiting? Yes. Are you any of you who have prescribed any antiemetic for anticipatory vomiting? We will go into it shortly, how we manage each of them. Okay, so why are we having an entire session on vomiting? Why are we so bothered? Okay, vomiting is another symptom, and you can give just an antiemetic. So why is it that we are giving so much of emphasis to control vomiting? Any suggestions on that? Why is it important to control vomiting?
It's electrolytemia.
It leads to dyselectrolytemia. and that itself is going to bring down the general condition of the patient. It could lead to electrolyte based issues. Absolutely. What else?
It's very disgusting to the patient
It
to be
is very
vomiting again and again.
distressful. Nausea, even though, yes, Dr. Kamafi also agrees to it's very unpleasant. Even though there is no much of content coming out, it's chronic nausea is very unpleasant for the patient, and it affects the quality of life of the patient. Palliative care is all about, preserving the quality of life, enhancing the quality of life, isn't it? And also, like Dr. Sudha was saying, dehydration for part of it. Dr. Raji was talking about the nutrition, compliance to the next cycle of chemo. Absolutely. It's so very important. And Dr. Abraham also talks about how the oral intake will be reduced. Absolutely. So all of you are, thank you so much for those answers over there. You're all absolutely right. It affects the patient's daily functioning, his quality of life, non-compliance to cancer treatment. So what happens? Say, suppose a patient is having severe pain and is on step 3 analgesics, probably morphine, and the patient is also having severe nausea and vomiting. And if that nausea and vomiting is not adequately controlled, he is not going to probably take even his analgesics. He's probably not going to retain them. He's probably going to vomit it out. And what happens is that altogether his functioning drops, and he is going to be like, I do not want any more further treatment. So, and in turn, what happens? The patient is in distress, and then which in turn makes the family also go into distress. So, coming to the causes of nausea and vomiting. So, we have different causes for nausea and vomiting, like you all were mentioning in the chat box. Chemically induced nausea could be one of them. Like, say, suppose opioid therapies, we have been talking about managing pain with opioids, right? Say it can be weak opioids like tramadol or codeine, or it can be strong opioids like morphine, right? So these drugs can induce vomiting. It can be self-limiting, so probably you need antiemetics only for the first few days. But definitely we know that, antibiotics, cytotoxics, these chemotherapy drugs, all these can cause nausea. And again, toxins, like through food poisoning, ischemic bowel gut obstructions, metabolic organ failures, like which could lead to uremia, for example. These all can lead to nausea and vomiting. Now, we also have some other causes like gastric stasis, which is caused by anticholinergic drugs. So, say suppose your patient is having severe colicky pain, and you prescribe the patient an anticholinergic drug. You prescribe tyrosine butyl bromide, buscopan. And what happens is that it can cause some amount of gastric stasis. Now, opioids also works in the same way. And you also have some other causes like peptic ulcer, gastritis, right? And also other causes like which causes the distension, the stretch of the GI tract, like constipation, intestinal obstructions, mesenteric nephritis, all which cause any distortion in the tract can also induce nausea and vomiting. So sometimes when patients come to us with nausea and vomiting, it is very important also to ask the bowel opening, a history on the bowel opening of the patient. When was the last time you had a normal bowel opening? Because if you ask them, are you constipated? Are you passing motion? They might say, yes, I am. But then whether it was adequate, probably they are constipated and they are passing very small amount of stools, again, that has to be, you have to ask leading questions sometimes and get the history out. And again, whether it is an intestinal obstruction that we are looking, it's not just a plain constipation, it is an intestinal obstruction that we are looking at. Then also situations like liver metastasis, ureteric obstruction, all this can also cause. Very commonly also, when mostly when our patients are on different pain medications, sometimes we tend to prescribe NSAIDs for bone pains. So this also can cause nausea. I remember I had this one patient who was having severe nausea and vomiting, and we were trying to control it, but mostly what happened was, he had a fungating wound. He had this fungating wound in his inguinal area, which was very smelling, foul smelling, and the smell itself was triggering the nausea and causing vomiting for this patient. So we need to actually look into what are the causes and then treat the cause. There might be a lot of antiemetics available, but we need to understand what the cause is, identify the cause, and see if it is reversible. If it is NSAIDs that is causing it and you cannot remove the NSAIDs, yes, you have to go along with it and give antiemetics and proton pump inhibitors to counter it. But if you can do without the NSAIDs, so you have to think about substitutes. Now, raised intracranial pressure, also like you were talking about projectile vomiting, right? So very typical, not followed by nausea. You have the patients have a projectile vomiting, and also vestibular disorders. Like movement-induced vestibular disorders, say like even for a normal person who takes a hairpin and just starts developing nausea and vomiting, can be one of them. Anxiety-induced, that's where the anticipatory vomiting falls in place. And again, like I was talking about the environment, we were talking like the example I was quoting, the smell, the food, or maybe it is not, the environment is not clean enough. The patient is in a ward, in a general ward, and his bed is right next to the washroom, and somehow it is not being cleaned well, or for whatever reasons, that is inducing nausea and vomiting for the patient. And always what happens is that most of our patients, who are uh, in the advanced state, they really need not have to follow strict a diabetic diet, strict a cardiac diet in advanced stage, okay, in advanced stages. Because what happens is that sometimes the families get so over enthusiastic and they try to make a food that is not actually palatable for them, when they actually need that amount of energy to keep them going. So sometimes we have to be flexible on that, because the food they might develop a distaste for food, and having food which is devoid of salt and bland food can again aggravate their nausea. So apart from this, do you think there are still other causes for nausea? Apart from this, what happens when you go examine? So patient is talking about nausea and vomiting, and you are prescribing antiemetic. You check for this, all list of causes, and you forget to examine the patient. You miss out something really important over there. Most of our palliative patients tend to have this. Yes, we have also answers coming here, like Yes, it can be drug interactions, it can be meds to the brain, or it can be migraine induced. Yes, these are all different reasons that we have to investigate and find out. On clinical examination, also another important thing that we have to look for is oral thrush. Most of our patients develop oral thrush, and this itself can cause difficulty in perceiving the taste of the food, or maybe it's burning too much, they can't have the food, or sometimes they have candidial esophagitis, which itself causes pain, and they are not able to swallow the food. They feel like the food is getting obstructed as they are trying to swallow it, and this itself causes a vomiting feeling. And if good oral care is not given, halitosis is another reason, bad odor, uh, um, smell from the mouth, and dysphagia, dyspepsia, hiccups, mucositis. Now, mucositis is also kind of common in patients who are undergoing chemotherapy. Okay, so these are all the different reasons and the causes. So basically, it is about how we have a checklist in our mind. And next time we see a patient who has nausea and vomiting, we need to identify under which of these is the cause for his nausea and vomiting. And we need to identify that and treat that as well. So, like for example, over here, if it is the oral thrush that is causing the nausea and vomiting, it is not going to help, isn't it? If we are just going to prescribe a metoclopramide or an ondansetron, we need to address that oral thrush as well. So you might have to give a clotrimazole mouth paint, or probably if it is too severe, we might have to give fluconazole orally. So now coming to choosing the antiemetic. So choosing the antiemetic, again, like we were saying, identify the cause. So identify what is the cause that is causing the reason for the nausea and vomiting. And once you know what the cause is, it is easy to identify which is the pathway that triggers the vomiting. And once you know the pathway, you will be able to know which is a neurotransmitter receptor that is involved. Now, once you know that, you can choose the most potent antagonist receptor that is identified. Now that you have identified all of this and you know, okay, it is this drug that is going to be the best for this patient, you need to choose how you are going to administer the drug. Are you going to give the patient always parenterally? Now, does nausea and vomiting always mean giving the patient IV? If the patient is able to tolerate orally, you can give the patient oral antiemetics. If the patient is having severe vomiting, unable to retain anything, you can definitely go for parenteral. Now, it is not just enough prescribing the antiemetic. It is very important to titre the dose. Maybe your 3 times daily is not enough for the patient. Maybe you have to make it QID, or maybe you have to also add in other antiemetics. Many a times there are situations where not just one antiemetic suffices. So you need to monitor the patient and make sure that your prescriptions are not on SOS or PRN basis. If your patient comes to you with vomiting, make sure that you have your drug chart planned in such a way that he or she is comfortable 24 hours round the clock. So check out the frequency at which it has to be given and correctly plan and administer. So like I said before, once you understand what is the cause of the vomiting, then you identify which is the pathway that is involved. And once you understand which is the pathway that is involved, you understand which is the receptor that is involved. So here in this diagram, many of you might be very familiar with this diagram. You can see what is the cause and which is the pathway. Say, for example, it is anxiety, anticipatory vomiting. Anticipatory vomiting, you can see that it is the pathway that is from the cerebral cortex, to the vomiting center, which stimulates the vomiting center to cause the vomiting. Whereas a biochemical upset, like something like or a drug like a chemotherapy, it affects the CTZ. It stimulates the CTZ. So the chemoreceptor trigger zone. Okay, now that is a pathway. Now that is why, like if you see in the left hand side below, the colors given there represent which receptor it is. So for chemotherapy drugs, as you can see, it is the CTZ zone where it acts, and the receptor here is 5-HT3, serotonin receptor, and to an extent the dopamine receptor. So then once you know which is the receptor, then you can identify which is the drug that is more suitable for your patient. So here is a chart which you will be given the slides, and you can have a look at this chart. Right now, I might just be going through it briefly, but just to continue with the example that we were talking about, some person who has come with a chemotherapy-induced vomiting, where we saw that it was the 5-HT3 serotonin receptors and also the dopamine receptors which was getting stimulated. So we try to find out antagonists for this. So 5-HT3, we see that ondansetron, granisetron, palanositron, all these are very much active to control the chemotherapy-induced vomiting, which acts on the 5-HT3 receptors, right? So again, ondansetron is available orally, granisetron is more parenteral, and probably given as pre-medications before a chemotherapy, but palanositron also is not something we can administer regularly, because apparently palanositron is best used with at least a 3 weeks duration gap due to its cardiac side effects. Okay, so please take your time on this chart once you get the slides. All right, so now the route of antiemetic. How do we administer? This is absolutely according to the patient's condition and preference. So oral route, as you know, it's always the best and it is the easiest, and it helps the patient to gain the confidence that his vomiting is going to be under control even when he goes home. Because if you have a patient who comes to you with severe vomiting, and you are admitting the patient and administering ondansetron round the clock, and the patient is become totally comfortable, no vomiting, and you discharge the patient. Once the patient is discharged and you change to oral medications, probably you might not be able to assess how comfortable he is on the same, or whether his symptoms are well addressed with your change in drugs. So it is better that before your patient gets discharged, you change all the parenteral medications to oral medications and carry on the same ones at discharge. So oral route is usually the best. And if the vomiting is severe, always go for IV or subcutaneous or continuous subcutaneous infusions. So I'm sure that in your previous classes, you may have been introduced about the subcutaneous route. This is one of the most preferred routes actually in palliative care, because most of the times, when our patients are really sick and at home, at bedside, when we are not able to get easy venous access for these patients. Sometimes putting in a butterfly needle or scalp needle as a subcutaneous and administering the drugs through that, it becomes much more easier. And it is quite preferred and it's very easy, less chances of infection, and so simple that even the family can administer the medicines as and when required after they be taught on how to do it. And even continuous subcutaneous infusions can be given through syringe drivers in the same way. Now, suppositories can be used. Sublingual preparations can also be used. There are these sublingual preparations of ondansetron, and children love it. It's a small little patch-like thing, usually very strong strawberry flavored or some fruit flavored it is, and they can just place it in the mouth and it just melts off. So ondansetron is also available sublingual, and then you also have transdermal patches in some places. So, non-pharmacological management. So, we have been talking about medications, isn't it? We have been talking about ondansetron, we've been talking about metoclopramide and all those things. Yeah, but then what about non-pharmacological management? Does non-pharmacological management even have a role to do? Definitely. We did see that environment is also a cause for nausea and vomiting. So, fresh air, bed rest to avoid vestibular stimulation, good oropharyngeal hygiene, and nursing in the upright position, because sometimes putting the patient supine without much head and elevation can also cause gastric esophageal reflux. Avoiding situations which induce nausea and vomiting. And also suitable distractions are other non-pharmacological ways how you can manage nausea and vomiting. Yes, we were having some comments here in the chat box, like Dr. Virendra was saying that peritoneal stretching during exploratory laparotomy can also cause nausea. Thank you for that point. And Dr. Abraham also says that, is this the mouth dissolving ondansetron preparation, or is it another preparation altogether, sublingual route? Yes, it is the mouth dissolving ones. It's the mouth dissolving. Right. So for distraction, this probably you need expert with helping you with this set of distraction techniques: self-hypnosis, progressive muscle relaxation, biofeedback, systematic desensitization. And most of the times, these distraction techniques are most useful in anticipatory vomiting. And what we need to know, like I said before, most often it is also seen that anti-emetic drugs may have to be used in combinations. Okay, and you can combine it with these non-pharmacological management also. And now, what about food? Because always this is like a very common recurring question. How do we, what food do we give the patient? The family comes and asks you, they're vomiting so much, so much of nausea, what to give, they're not eating well. So what we need to advise is small frequent meals rather than the 3 large meals, and try consuming most foods during the time of the day when they are able to eat better. So most of the times it is seen that, sometime in the morning, say about like 9 o'clock, 10 o'clock is when they eat better. And then also try to take foods which are easy on the stomach. And try not to force food when they are not safe. Cold food or at room temperature are better tolerated. Having said that, sometimes, it also depends on what the patient prefers the most. So even though we talk about cold food, in some most of the times in an Indian scenario, we are so comfortable with warmth. So maybe not boiling hot, piping hot, but maybe a room temperature food would be more suitable. Right. Now, trying to avoid fatty food, sweet, spicy food, because this all can further aggravate the nausea and vomiting. And avoid fiber. Now, avoid fiber is keeping in mind the constipation, which further can, in case of intestinal obstruction, it can further aggravate the constipation, and this can further worsen the nausea and vomiting. So, it is also seen that many of the times, I mean, it's the elderly people who are living alone, they have to cook for themselves. So even the patient who is having vomiting and nausea is having to cook food. And that is one thing that we could suggest to them. Try to tell them that, that could be one of the reasons that they are feeling nauseated. When you are when you are having to cook food and eat by yourself. So that if there is an alternative arrangement that can be done, that could be probably advised to them. And if the patient is having difficulty in eating his special diabetic or heart disease diet, their diet requirements can be relaxed at this time. And not relaxed to a hazardous level if we are, if the patient is not so advanced. And, coming to the point, like, that palliative care starts from diagnosis, isn't it? So right from diagnosis till death, palliative care goes on. And even after death, palliative care continues as bereavement care. Okay. So what I wanted to just emphasize over here is that as we are taking palliative care along with the curative treatment, in the initial phases, the role of palliative care might be minimal. But as the disease is advancing, the role of palliative care increases and the curative care is much less. So in the initial phases, when the curative aspect is of higher proportion, we might have to be really aggressive in our management. So at that point, having to completely relax the diabetic or the heart disease diet may not be completely advisable. So this usually happens in the latter part when, the patient is mostly under palliative care and when the patient is having an advanced disease or an terminal. We get really flexible on, not being so stringent in maintaining his cardiac diet or diabetic diet. Because what we try to focus is on getting the patient to be nourished enough for the energy level he requires at that point of time. Okay. A dietitian can be consulted to provide more tips to help in the eating. So what is important? It is very important to keep the mouth clean, do a good oral care after each episode of vomiting, and wearing loose fitting clothes, and having fresh air by keeping the window open, and limiting the sounds, sights, and smell that can cause nausea and vomiting. And also it is very important to keep contact information with the family or the patient to contact you in case he is not having relief of symptoms, so that you can advise on what should be done further, how the frequency of the medications can be changed or the dose can be changed, or what additional antiemetics could be taken along with. So nausea and vomiting management guidelines in palliative care is history taking, very important. Find out what the cause is. Then once you know the causes, you need to identify whether the cause is reversible or is there any exacerbating factors there, like drugs or constipation or severe pain or any infections or cough. So any of these things, if it is a trigger factor, you try to focus on that as well. So relieve the constipation, bring down the pain, control the infection. For example, urinary tract infections. In elderly, they could have urinary tract infections can present very bizarrely. They may present maybe just as vomiting. There may not be any fever. It may be just body pain and vomiting. So try to tackle the main cause also as you are controlling the symptoms. If it is the drugs that is triggering it, try to substitute the drug if required. Now, you review the patient after 24 hours. If the nausea and vomiting is persisting after 24 to 48 hours, the patient will need more than one antiemetic. If on parenteral, convert to oral after 72 hours of good control to a oral regimen. That is a golden rule. So these are all the different antiemetics. It comes under different groups. As you all know, this is all very familiar to you all. Anticholinergics, D2 blockers, then you have the prokinetics, which we most often use, like metoclopramide, domperidone. And then you have the NK1 receptor antagonist, aprepitant. Aprepitant is very preferably used now to address anticipatory vomiting. So when we see patients in the chemo ward with severe anticipatory vomiting, we start the patient on aprepitant. Aprepitant comes in an oral form, and it is a strip with 3 tablets. So the first tablet of 125 milligram and 2 other tablets of 80 milligram each. So the first tablet is given before the chemo is administered. The second tablet and the third tablet is asked to be taken on day 2 and day 3. Okay. Then you have H1 antihistaminics, and you also have the 5-HT3 antagonists. And then you have the adjuvant antiemetics. Now again, the adjuvant antiemetics most often used by us is dexamethasone and benzodiazepines. Now these are drugs which we use for refractory vomiting and anticipatory vomiting. So if you have patients who have anticipatory vomiting or refractory vomiting not responding to your 2 different type of antiemetic combinations, then definitely try adding dexamethasone or benzodiazepine. Short-acting benzodiazepine like lorazepam is given as HS dose, and that helps. So this was our checklist on what are the causes, and these are the drugs which is preferred. Haloperidol can be started from 1.5 to 5 milligram per day, can be given orally or subcutaneously. The Serenase that can be given for opioid-induced vomiting, most often used, and sometimes it can be used for controlling vomiting in other causes as well. Okay, metoclopramide 10 to 30 milligram can be given 4th hourly, 6th hourly, 8th hourly. Severe causes, we sometimes have to also give it as short as 2 hourly. Okay, domperidone again 10 to 30 milligram can be even given 6th hourly, 8th hourly. Okay, and the thing is that these two have also a prokinetic effect. So you can think of giving metoclopramide or on the domperidone for your patients who is having constipation. So, but now, what happens when your patient is having severe abdominal colic? Okay, your patient is having severe abdominal colic. You find out your patient has intestinal obstruction. So your patient is having intestinal colics and is having an intestinal obstruction. Now, you are giving and is having severe vomiting. So to control the vomiting, you are giving metoclopramide. Now, what happens when you give metoclopramide? It is a prokinetic. So when you give a prokinetic for a patient with intestinal obstruction who is having abdominal colics, the prokinesis itself increases the abdominal colic. So that is when you have to think about other antiemetics. I usually go for haloperidol at this time. And ondansetron is also my other choice. Also keeping in mind that ondansetron itself worsens constipation. So ondansetron again is also commonly used. We also have another whole list over here given for controlling vomiting. But again, I would like to also put in a word about using hyoscine butyl bromide. Okay, hyoscine butyl bromide and octreotide are two drugs which are also used to control nausea and vomiting for its anti-secretory property. So patients who have severe large volume vomiting and you want to decrease the vomited volume, you can go for anti-secretory agents such as hyoscine butyl bromide or octreotide. And again, dexamethasone overall also helps to decrease vomiting. Now we move on to constipation. Now constipation, again, when you ask the patient what is how is your bowels, and they tell you, oh, I am constipated. Now you need to exactly find out what is the problem that they are having. Maybe the patient's normal bowel movements is only once in 2 days, and that has always been normal for him. So having not passed stools after 1 day is not abnormal for him. So you need to find out what exactly he means by constipation. Is it the difficulty or the pain that is associated with it? Sometimes constipation causes hard stools, which causes pain. And every time the patient is trying to pass stools and the rectum gets dilated, it induces more pain and it further aggravates the constipation. So you need to exactly find out what exactly is the cause. Where is it the pain or is it the infrequent bowel movement, the evacuations, or is it that the patient is passing very small, hard stools? So you need to sometimes ask even leading questions for that. And the whole subjective feeling of how it is different from their normal. Like I said before, sometimes once in 2 days, once in 3 days is normal for them. 45% of palliative care patients are constipated on admission, and that is why we need to understand a lot more about constipation. It is a feeling of incomplete evacuation. Some people say it is a very bloated feeling. It causes nausea and vomiting. It may cause cramps, abdominal pain, and the patient has features of bowel obstruction. So you don't know whether you're looking at an intestinal bowel obstruction or are you just looking at a plain constipation. You can understand that better by examining the patient, looking for bowel sounds. So most often what you see in constipation, you hear bowel sounds, and sometimes in total intestinal obstructions, the bowel sounds you hear, if at all you do hear, generally you do not hear, but if at all you do hear, it is over-exaggerated, that we call as Borgagni sounds, right? And now there is also another entity when a patient comes to you and tells that he is having diarrhea. Now, again, asking questions about diarrhea, you do not immediately start treating the patient for a diarrhea. You need to ask the patient when was the last time that he had a normal bowel opening. because you could be looking at overflow diarrhea, which is the sequelae of constipation. So as you all know that, say suppose the bowels are not open for like days together, the upper part of the bowel, which is collected, starts to necrose and starts trickling out as liquid. Now, this is perceived by the patients as diarrhea, as loose stools. So you need to ask the patient, but when was the last time you passed stools? And they might say, oh, that was about 1 week back. And now for the past few days, I'm just having them. So now for these patients, you do not treat it as a diarrhea. You treat it as a constipation. You need to do an examination of the patient, do a rectal examination, see for loaded fecal mass in the rectum, or you might see ballooning of the rectum because the loaded mass is higher end, right? These two the findings will tell you that you are looking at an overflow diarrhea. So what you could do is that probably manually, digitally evacuate the stools, the loaded stools in the rectum, and give a high-end enema if required, or you can just give a plain enema or a suppository and allow for the bowels to open. So as you can see, we treat it like a constipation when a patient is still coming with complaints of loose stools. So it is very important for that. Now, urinary retention. Yeah, it has happened so many times, I go for home care. The patient tells that the urine is not draining well from the Foley's catheter. And they are just, changing the catheters or, flushing the catheter, and then it works for some time, but it keeps recurring. Many of these patients, if you do a digital rectal examination, you can see that there is a loaded rectum. And that is causing pressure over the bladder, which is causing urinary retention. These patients are more prone for urinary infections. Now, what can cause constipation? It can be any of the drugs like opioids, antidepressants, anticholinergics, antiepileptics, antiemetics like ondansetron that we were talking about. Somatostatin analogs like the octreotide we were talking about, that we were saying that is an anti-secretory agent, right? Octreotide. So these things can cause constipation also. Metabolic reasons like hypercalcemia, dehydration, hypokalemia, uremia, all these things can cause constipation. Diet, low fluid diet, poor appetite, or environment, hospitalization. See, if a patient is hospitalized and unable to pass stools, we need to also consider the environmental factor. It's hospitalized, he's unable to go in a new environment. Or what if it is in a ward, in a general ward? Or, the difficulty in passing stools into a bedpan, or maybe that, inability to attend the call. The patient wants to go to the washroom, but there is no enough support factor to take the patient to the washroom. So this is building up within him or her, and which is led on to a constipation. So these also have to be looked into. Neurological factors, malignant spinal cord compression. In spinal cord compression, by the time the anal sphincter function and all is lost, it is a very poor prognosis. So a constipation is also seen in such cases. Sacral nerve infiltrations, also pelvic tumors, radiation-induced fibrosis, painful anorectal conditions, right? And also depression or weakness, immobility, inactivity, sedation, old age, all these things are itself causes for constipation. So you need to see which among these are reversible. Is it your drugs that is causing it? Is there a way that you can go for alternatives? Is it your metabolic parameters of the patient that is causing it? Is there something that you can reverse so that it doesn't keep happening off? What is normal for the patient? So this is through history taking. Find out what is normal for the patient, the frequency, amount, consistency. Is it blood stained or not? When was the last bowel movement? Also ask the patient, are you experiencing any abdominal discomfort, cramping, nausea and vomiting, or any excessive gas or rectal fullness? You ask the patient, are you having belching? Are you passing gas, flatus? So all this will also give you passing flatus is actually good for us. At least we are not looking at an intestinal obstruction. So does the patient regularly use laxatives? So this is again a very important thing. You are seeing a patient who comes to you, tells you that, doctor, I am constipated. I'm not able to pass stools. Next thing you ask them, are you taking laxatives? They tell you, oh, yes, I am taking laxatives. Now, this is a point where you have to ask questions again and again. Which laxative are you taking? Okay, I'm taking loose laxative, lactulose. Okay, so how much of it are you taking? I'm taking about 5 ml. Now, 5 ml is not going to help you, isn't it? We generally say to take about 30 ml. And if the patient is taking 30 ml at night and is still not able to open his bowels, we tell the patient to take 30 ml 3 times a day till they develop loose stools. Then skip the dose for the following day and then take it from the next day onwards every night. So laxatives, you need to find out whether the patient is taking regularly in the prescribed dose. So they also have a lot of fear for laxatives because most of the times the practice that is seen is that they keep waiting. Patients develop constipation, they wait for a day, for a 2, for 3 days, 4 days, and then they take laxative. Now, when they take laxative, the first dose, nothing happens. Second dose, nothing happens. Maybe the third dose is when it happens. When the bowel opens. And once the bowel opens, they have a purge. And they have even trickling sometimes, because there's an entire bowels that is getting washed in the process. Now, what happens is that they attribute the entire issue to the laxative. So they think that, patients think that if you take laxatives, you will have a bowel purge like this and you will have trickling of a bowel. So this is also very important to make them understand that you take your laxatives after a day of constipation so that you do not land up having a severe loose stool purge or trickling. And is constipation a recent change? Again, we need to find out, are we looking at plain constipation or intestinal obstruction? And what type of diet is a patient on? Now, this is also very important in our settings when patients depend on alternative medicines or maybe some new type of fruit or something that, is being talked about amongst friends or social media or something. We do not know what has actually led to the new onset of their symptom. So always ask them, has there been any change in your diet, any new food or any medication that has been. Now, this is a very common issue when the family comes and tells you that, oh, doctor, he has not been eating enough at all. Then how will he pass motion? Now, what you need to make them understand is that if he or she, the patient, does not eat enough, there is always intestinal secretions which amount to stools. So there has to be a bowel opening at least once in 2 days or 3 days, right? And again, I have diarrhea. When the patient comes and tells you, you need to make sure that you are not looking at overflow diarrhea, okay? So management of constipation, correct the correctable, judicious use of laxatives, improve the general condition, symptom control, encourage activity, and high fiber diet. So non-pharmacological management, again, able to go to the washroom, the support system to go to the washroom, and the timing and privacy, whether the patient is having adequate privacy for opening his bowels. Then sometimes we also say about trying positions like squatting position, and this also helps in easy bowel opening. Encourage normal balanced diets and a lot of fruits. Now, management, you have to do a rectal examination, and if there is hard stools, you have to digitally evacuate it, right? And while doing a digital evacuation, you have to be as gentle as possible. Explain what you are going to do to the patient. It is not a comfortable procedure for a patient. So use enough amount of lubricant, lignocaine jelly, right? And when suppositories are placed, even tell the families how when suppositories are placed, they have to be placed in such a way that they touch the rectal mucosa. Sometimes what happens is that if they do not put the suppositories properly and the rectum is loaded, the suppositories that they put into goes into the fecal mass. So it is very important that suppositories are in touch with the mucosal surface so that they can stimulate the contractions. Now, enema, glycerin enema or saline enema or proctosodile enema, any of these can be given. And generally we say not to give soap and water enema for hygiene reasons. And types of laxatives, we know there are different type of laxatives. All are very familiar with this. Bulk forming laxatives, lubricating, osmotic laxatives, stimulant laxatives, stool softeners. So for opioids induced constipation, we generally always prescribe stimulant laxatives along with opioids. Although we say that nausea and vomiting is a self-limiting symptom for those taking opioids, constipation is not self-limiting. So patients who are on strong opioids like morphine have to be given laxatives as long as they are on opioids. Okay. Right. Polyethylene glycol, lactulose are also very commonly used osmotic laxatives. And sometimes lactulose is not so preferred by many of our patients for its sweet taste. I try to put patients on lactulose if they also have liver impairments. Now, few recommendations. Paraplegic patients need regular stimulants and stool softeners, which can be used as regular basis. Now, paraplegic patients often, bowel opening is an ordeal. Some of their family members are also, they time it in such a way which they are also able to facilitate it in the best way possible. So sometimes they put suppository for the patient once in 3 days, which is most comfortable for them. Unless and until that you find out through history taking that the patient gets restless by the second day evening because of the bloating and all that, you might have to advise the family it is better that you give the suppositories or put the suppositories every alternate day itself. Then if the manual evacuation is required, yes, you will have to do that. And patient with colostomies are also treated in the same manner. Okay. So it depends whether the patient is having soft stools or hard stools. So if the stools are hard, glycerin suppositories can also be used. And high-end enemas can be used if there is a ballooning of the rectum. You do a digital evacuation and you see that the rectum appears ballooned. This is because the obstruction is at the higher level. So then you give oral stimulants and you give a high-end enema. Okay. Now, Bisacodyl are glycerin suppositories, and plain water, saline enemas, sodium phosphate enemas, oral laxatives, all are different options. Like I said before, manual evacuation, be as gentle as possible and explain to the patient well in advance what you are going to be doing. Right. So quickly going through bowel obstruction. Sorry, I'm having to hurry through all this. So bowel obstruction, again, when you are looking at bowel obstruction, you need to make sure that this is not just a plain constipation, or are we looking at intestinal obstruction? Now, again, in intestinal obstruction, are we looking at mechanical intestinal obstruction, where you have something really sitting there to obstruct it? Or are we looking at non-mechanical obstruction, where it is simply because the ileus or the colon has lost its peristaltic property? Okay. So the causes of bowel obstruction, it can be anything. It can be intraluminal, it can be intramural, or it can be extramural or adynamic causes. So intramural, where you have actually, foreign bodies obstructing, or intramural, where it is a stricture in the vessel, in the wall, in the intestinal wall. There is a stricture, or there is a malignancy which is invading in and obstructing. Or it could be extramural, where there is, because of multiple surgeries or radiation, there are bands and adhesions, or it could be just a hernia. And again, we have the adynamic causes like paralytic events, right? Now, what causes the symptoms in intestinal obstruction? When there is a partial or complete obstruction, there is colicky pain, there is decreased intestinal movements, and all this leads to bowel distension, because there is an increased collection of the bowel contents, and the distension itself increases the gut epithelial surface. Now, this will lead to a lot of inflammatory response and factors which are released, which further aggravates the pain. Bowel distension with accumulation of the the gut secretions lead on to nausea and vomiting. So this is why a patient with intestinal obstruction may present to you with severe colicky pain, with vomiting, nausea and vomiting, and we have to find out where the obstruction is and how to stop it. I mean, how to reverse it if possible. Now, how do we define where the obstruction is? Now, are we looking at ileal obstruction? Are we looking at a colonic obstruction, large bowel obstruction? Now, the first thing that comes into our mind is that we can take a CT scan and check, isn't it? So, what else will tell you where the obstruction is? You're in a bedside and you are at the patient's home. The patient tells you that vomiting, he's been having severe vomiting, and it's so much of volume of vomitus, then it is sure that it is a higher level of obstruction. Now, if it is a large bowel obstruction, it is more progressive, and the bowel distension is generally more than the high level obstruction. And if it is a complete obstruction, there is no passage of places or feces, and the patient could probably have serious diarrhea. So if it is a large volume vomiting, and the vomiting is the most prominent feature, you're probably looking at a high level obstruction. If it is more of a progressive kind of obstruction, and the bowel distension, the abdominal distension is more, it will be most probably a large bowel obstruction. And how do you make out bowel obstructions? We take a abdominal erect X-ray and we check for the air fluid levels, right? And this is exactly what you can do to confirm whether you're looking at an intestinal obstruction. In the same time, if it is a constipation related obstruction, you can see the loaded colon instead. Okay. Now, when do we say, okay, this patient is having intestinal obstruction, take him for surgery, or we say that, okay, this patient is having intestinal obstruction, it carries a poor prognosis, so let us manage him conservatively. Now, these are the few points. Advanced stage with cachexia or a widespread tumor, deranged metabolic parameters, ascites, low serum albumin, severe nutritional deficiency, palpable abdominal mass, previous radiotherapy, history of multiple chemotherapy, second-line chemotherapies, multiple sites of obstruction, poor peristalsis due to diffuse carcinoma peritoneum, and poor performance status of the patient. So it is not the age alone of the patient that makes you decide whether this patient goes in for surgery or not. It is so many other factors. If the patient has multiple levels of obstruction, there is no point doing a surgery and putting a colostomy, isn't it? Now, so how do you medically manage such a patient? Corticosteroids are the most important drug that is given. Dexamethasone, 16 milligram. In my practice, I sometimes go all the way to about 24 milligram easily. 24 milligram, 16 to 24 milligram subcutaneous or IV. Give a 3-day trial. Check for symptoms, the appearance of bowel sounds or the passage of flatus, and the symptoms that are controlled will be observed, and thereafter the decision of tapering the steroids is also done, or sometimes they are stopped after the trial and the patient is not getting better. Now, metoclopramide can be tried if there is no abdominal colic. Okay, like I said before, it is a prokinetic. So having given antiemetic, which is a prokinetic, may aggravate the colic of the patient. Hyoscine butyl bromide can be given for those patients with severe abdominal colic and with large volume of vomitus, because hyoscine butyl bromide also helps to decrease the secretions, the gut secretions. Haloperidol again can help to decrease the nausea and vomiting in the patient. Patients who have a colostomy, this is just a slide to show you how they can, okay, I'm sorry, did I get to the last slide? Okay. So this is in a nutshell how we manage a intestinal obstruction. Okay. And now just to add on, if your patients are having a colostomy, always educate them about how they can do a bowel irrigation. So they can time their bowel movements from the colostomy. Okay. From the stoma. So this you can see the different parts of the technique that is applied here for the irrigation. You have an irrigation bag with a clamp in one end, okay, which is attached with a tubing. Now the little funnel shaped thing that you see in the end is being put into the stoma. Okay, is being put into the stoma, and the just lukewarm water is let to run from the irrigation bag through the tubing into the stoma through that. Okay, through that funnel shaped thing, that conical thing. Okay, and once the entire bag is complete, okay, the fluid is run completely, then it is detached. Okay, it is detached, and the bowel is let to wash out with the help of the sleeve into the commode. So if the patient is going to do this for about 28 days, 21 to 28 days, every day morning at a particular time, say like 7 o'clock in the morning, the patient's bowels are going to get into a habit of evacuating every day at that same time, and he's going to have most minimal secretions to the entire part of the daytime. Right? So now we have almost come to the end, and another 10 minutes that we have. We're going to come back to this case scenario. Okay, so this is the same case scenario that we saw earlier. Now, I just want you to look at this case scenario from what we have dealt with in this topic in the past 1.5 hours almost, right? And I want you to realize whether you have been able to think differently. Right? So this is a 54-year-old lady with stomach cancer who is on chemotherapy and is admitted in the general ward for treatment of urinary infection. And she is admitted with vomiting, abdominal pain, and fever. And she is tired and admitted for completion of IV antibiotic. She has small, frequent, incomplete bowel movements for 4 days and is started on laxatives today. And she's accompanied by her younger daughter. Okay. Now, what are the issues that you see here? What are the reasons for the vomiting, colic, and fever? Yes, you can use the chat box or you can unmute and say. What are the reasons for the vomiting, abdominal colic, and fever? When did she get her chemo? The chemo was given very recently. She is on chemotherapy. Yes, it could be the CA per se, it could be the chemotherapy drug, or it could be the urinary infection, right? Which has led to the vomiting. And also, we are looking at something. She has small, infrequent stools, which is probably because of the chemotherapy, which is probably because of the dehydration that has happened because of the vomiting, or the vomiting itself could have led to probably hypokalemia, which could have also aggravated the constipation, right? Now, all these things together, the abdominal colic fever could have been probably because of the urinary tract infection, isn't it? Now, her symptom of constipation could have also been because of the environment, that she is in, the general ward, being accompanied by her younger daughter who is unable to support her completely and take her to the washroom. We have to now start thinking about it in different ways. Yes, Dr. Abrams was asking about has she been evaluated for neutropenia as well? Definitely, she's been neutropenia. She has been evaluated for neutropenia. Her total, her ANCs are fine. Yeah, but she does have, she did have about 50 to 60 pustules in her urine, and the cultures have been sent for. Yes, Dr. Rajiv sir was also talking about serum electrolytes, direct abdominal X-ray, which will tell you, will give you a lead. Are we looking at an impending intestinal obstruction? You might see either a loaded colon or you might see like air fluid levels, right? So how would you investigate as an exercise? And that is where we got the answers over there. At the same time, you can also do a simple clinical examination check for bowel sounds. You can do a digital rectal examination. You can check for impacted fecal mass. But let me tell you one thing, patients who are on chemotherapy and if at all they are neutropenic, it would be the worst time to do a rectal evacuation, a digital rectal evacuation, because generally rectal examinations are avoided at this time. You do not want to cause any injuries in the anal area when the patient is neutropenic. How would you manage? The patient is already on antibiotics for the urinary tract infection. And how would you like to manage the vomiting, abdominal colic, and the constipation? Yes, Dr. Abrams was talking about may still be better to keep in a private room since chemo was only 3 to 4 days ago, and another may be taking a little longer to arrive. Absolutely, sir. Definitely, the general ward may not probably be the best setting for her at this point in time. And coming to the management of vomiting, abdominal colic, and incomplete bowel movements, which drugs would you suggest? Dr. Rajiv sir also tells about the blood pressure, capillary filling time for dehydration, CRP, PCT, see if the antibiotics are working. We can check various inflammatory levels to see how the infection is responding to the antibiotics. And how would we manage the vomiting and the colic? What antiemetic would you like to suggest for this 54-year-old lady? We did go through a lot of antiemetics. So which antiemetic would you like to suggest for this lady who has developed severe vomiting, abdominal colic, and fever? And constipation. We can try prokinetics since she is passing schools. Prokinetics can be given for patients who have severe constipation because it helps to propel the fecal mass further. But in a case scenario where there is abdominal colic, we might have to also think about how it may aggravate the abdominal colic. So we will also have to use medications such as buscopan or dicyclomine to tackle the abdominal colic, right? Antispasmodics, absolutely. And yes, we also have here suggestions like Dexona, and dexamethasone would probably be used for patients who are having intestinal obstruction rather than constipation. And for vomiting, it would be rather used for patients who have refractory vomiting, are not responding to usual antiemetics, right? And Dr. Virendra says, apart from directly causing nausea, chemotherapy leads to cellular damage or death. Toxins thus formed or released would add to the nausea, and then the cytokines would also contribute to the nausea. Thank you for adding in that point. And then we have Dr. Rajiv saying that, yes, antispasmodics like Drotin can also be used. Yes. So the point that we need to bring out over here is how it is more clear over here that it is more of constipation that we are looking at, and which itself can probably aggravate the vomiting, and how the constipation has to be also addressed as we are managing the vomiting and abdominal colic of the patient, because it all might tend to aggravate each other like a vicious circle, right? Olanzapine and Dexa are commonly used as part of post-chemo medication for chemotherapy-induced nausea and vomiting. Absolutely, sir. Yes, it helps a lot. Antipsychotics, olanzapine has also been found extremely helpful in controlling nausea. We may, yes, Dr. Always also says that we have many who get settled with thiamine infusion. Okay, thank you so much for adding that detail. Would you like to just add in a few details on that? For thiamine infusion for vomiting, is it? Nausea and vomiting, is it? For vomiting. Okay, okay.
Dr. Ahmed, would you like to tell a few words about your experience in thiamine infusion? Because that's something like what is the intent, how does it act, and how will you give thiamine infusion, etc. Just a few points.
Actually, ma'am, we were using it from last 6 months here. Usually, many of our patients didn't still settle with the other antiemetics. So we start to give them thiamine. Maybe there is any deficiency. I'm telling about the post-chemo nausea and vomiting. Regarding that only. Post-chemo nausea and vomiting, settled with this thiamine thing. I don't know whether there is any deficiency with chemo medication or whatsoever it is. So actual mechanism, I don't know how it gets, but many of our patients, we give them 200 mg of IV this thiamine, 100 ml of NS, and I think just in 1 day or 2 they get rid of the nausea and vomiting.
You
Is
continue
that
for a
without
few
side
days or
effects?
just once? How long?
No,
will
no,
you-
no, no. We continue for up to 3 days. We continue for 3 days. Apart from other emetics, we add this thiamine thing with this.
So
So
the
we get
patient will be with you for 3 days, right?
no. They come to our daycare. We have palliative care daycare there.
Okay,
They
you put
come
it
to us.
like once and then send them back home.
Yeah, yeah,
Okay.
and they get in a very first infusion. They get a lot of about 60-70% relief from this nausea and vomiting. There is almost if they are vomiting it for 2 to 3 or 2 to 4 times a day, then only single time they vomit after the first infusion of thiamine. But I don't know the exact mechanism. What is the exact mechanism behind? It's like actually we gave patient thiamine once for something else, but he was having this recurrent vomiting. So it was like what can I say? We got it by chance, and still we are using this in post chemo nausea and vomiting. Our patient gets settled with this.
Always, can I just
That's a
ask you a quick question? Is this anecdotally something you're trying at your facility, or is there actually literature out there where this has been done before? Thank you.
Actually, the people in our oncology section, usually they are working on it. They start this thing with using thiamine in our post chemo patients. So eventually, actually, they are working on it. So we also started the same thing, but we get good results from this.
Thank you.
It was not there was no literature behind this. So I think maybe there is some thing, there is some clinical this, or it's proven something somewhere, but not like it's not evidence based anywhere.
Thank you for that info. It's given us all something to take back, to look back.
You can use it. It is confirmed that we get patients settled with this thing, and you can try it. It is there's no harm in trying this thing.
Thank you so much, Dr. Lawrence. So I think it's almost time that we conclude with today's class. And yes, just to summarize, the correctable, non-pharmacological management, pharmacological management, and intervention. Also, always remember every symptom is multidimensional. As you address the physical symptom, also address the psychological, spiritual, and the functional concerns of the patient at the same time. So thank you, everybody. This is my reference, the Oxford Textbook of Palliative Medicine. Yes. Do we
Thank
have
you.
any questions?
Thank you, Vineetha. If there are any other questions which was unaddressed or not talked about, you can ask now, or we can wind up today's session. I think. Thank you so much. Yes, Dr. Geetanjali, are you trying to tell something? Thank you so much, Dr. Vineetha, for I know this topic is very too much to cover in one session, but thank you so much for covering it really well, touching upon all the important points and with the interactions in between. Thank you so much. Thank you so much, all the participants, for your time, and we will have more sessions in the coming week. Hope to see more interactions in the coming sessions. Thank you so much, everyone. Shripriya?
Thank you, Dr. Vineetha. Listening to your sessions has always been enlightening, and I believe that today also each participant would have felt the same. Thank you so much for finding out time to join us. And thank you everyone for making the session interactive. Before logging off, just an information that we will not be having any session on 2nd of October, coming Monday, on to Gandhi Jayanti. So we will meet again on 3rd of October, Tuesday, with another important session and yet another eminent faculty. With that promise, this is Sripriya along with Dr. Vineetha Rijju and Dr. Sridevi Warrior signing off from the Tipseco Hub. See you in the next session. Till then, everyone, take care. Keep spreading happiness. Bye-bye.
Thank you all the participants. Thank you, Kali and Indian. Bye. Have a good evening. Bye.